important thing you need to remember is your where does this drugs act. Okay, I will cover individual drugs in a very rapid way, but this is a full diagram. On the right side of the screen you can see this is the axonal terminal site, where you can see this is the nerve vesicles which are filled with the neurotransmitters, and on the left side of this diagram you can see this is your alpha to delta subunit of receptor. So this is the site where your primarily the pregabalin and gabapentin is getting attached. So what does they actually do? So they inhibit the calcium influx from here to here. Okay. So what does calcium does here? It disrupts this synaptic vesicles. So it inhibits the disruption of synaptic vesicles so that ultimately the lesser number of neurotransmitters are released in the synaptic cleft. So there are few glutamate receptor which are available, and as you are well aware that glutamate is your excitatory transmitter, so it's get inhibited. Okay, and sometimes also the gabapentin acts on this postsynaptic receptors, bind to them, thereby decreasing the number of active sites. So there are two things, one is the alpha to delta subunit and the postsynaptic kind. Okay, so this is the primary mechanism of your this alpha to delta ligand. So coming to individual drugs, I'll cover in a rapid way. So valproic acid, yes, sodium valproate, or definitely you can use it in the different types of headache. Nowadays, the primarily prophylaxis used in the migraine or the cluster headache and the tension type headache. Yes, how it's acting? So it inhibits the GABA aminotransferase enzyme. So what happens? So the GABA degradation is inhibited. So more amount of GABA is available in the synaptic cleft. So as you well know, it's an inhibiting neurotransmitter. So the pain is getting inhibited. So dose, yes, definitely it's 250 milligram. You can start in a HS dose. Then you can, after a 1 week trial, you can increase the number of dose to BD. So 250 BD. So TDS you can also use. So as with all the anti-neuropathic medication, just you have to start low, go slow, and then increase in a week, or you can say 10 days after slightly effect. Okay. So metabolism, yes, absorbed rapidly, and peak concentration in 1 to 4 hours. 90% is bound to plasma protein, and half-life of 15 hours. Side effect, definitely it has got CNS depression, hepatotoxicity, or hematologic toxicity. So as I told you, it's a prophylaxis of migraine. It's now the pain physician are using as a primary prophylactic medication. Then other indications are TM joint dysfunction and the phantom limb pain. So what does it does is another is this clonazepam or benzodiazepine. So benzodiazepine, where does this act? Medication. This is another anti-epileptic medicine. So it's bind to the alpha subunit of your GABA receptor, and it increases the frequency of chloride channel, and thereby reduction in the pain transmission. Okay. So mechanism of action, yes, as I told you, it enhances the GABA receptor mediated chloride channel opening and thereby affected it. But individually, you can think that it's not so effective. But whenever it is combined with other anti-neuropathic agents like pregabalin or gabapentin, it is definitely effective. So the only benzodiazepine which is effective against neuropathic pain is clonazepam. Just for exam going students. So yes, doses you can use it at 0.5 milligram dose at the bedtime, and then gradually increase the dose. Okay, so metabolism, yes. One thing important to remember is 85% plasma amount. So very few amount is available as a free. Okay, and that's why it has got half-life of a longer duration, so 24 hours. Okay, side effect, yes, as like other benzodiazepine, it has got drowsiness, dizziness, fatigue, sedation, and dependence is definitely there. Okay, so definitely sometimes can be used in post-herpetic neuralgia or diabetic neuropathy. Gabapentin, sorry, I was talking about this gabapentin. As I told you, that the mechanism of action is completely this inhibition alpha on based on the alpha to delta unit subligand inhibition. So it ultimately what happens? This glutamate receptor is overcaptured, and the glutamate, lesser amount of glutamate is available in the synaptic cleft. So there is these are the, you are well aware of that. These are the facilitatory transmitter of this pain, especially for the neuropathic pain in the CNS or the peripheral nerve fibers. So it is particularly effective in neuropathic pain condition, especially for PHN or the diabetic neuropathy, which are the FDA approved indications. So as I told you, as these are the vesicles, so that are filled with the glutamate. So there is calcium. It is inhibiting the calcium influx from here to here, and thereby lesser amount of neurotransmitter is getting released. Okay. So this acts on alpha 2 delta subunit. Okay. Doses, yes, always start with a go low and go slow. So you can start with a say 100 to 300 milligram HS dose, and then gradually every week you can increase the dose. Okay. So especially all this anti-neuropathic medication, you have to warn the patient or just advise the patient. The patient might feel dizzy in the morning, especially with the elderly patient, and they have got tendency to fall. So just go with the lower dose, especially with the elderly patient. Okay. And they have got reported adequate pain relief with the doses of 900 to 2400 milligram dose. And especially this gabapentin, you can use it at TDS doses. Okay. So metabolism, yes, half-life, it has got 5 to 9 hours. And side effect, definitely I told you the somnolence is there with this. Okay. And there is ataxia and fatigue. Yes, dizziness is there. The pregabalin, that is the second example of alpha 2 delta subligand. So this is FDA approved for this fibromyalgia, DPN, this fibromyalgia, and sometimes it can be used as spinal cord injury pain or the central post stroke pain and other conditions like post herpetic neuralgia. So definitely it has got advantage more over gabapentin, that it has got faster onset of action. But in terms of side effects, when you're talking about, especially in the elderly patient, pregabalin has got a tendency to retain water. So it is more likely to cause heart disorder in the cases of when you use it for a longer duration, especially in elderly patients. Okay. So as I told you, it's another example of alpha 2 delta subunit. So dosing, especially when you start again with a 75 milligram. Nowadays, some preparations are available where 50 milligram tablets are available, but 75 you use it, and you can get an onset within 7 days. Okay, maximum of 7 days, 7 to 10 days. So especially the acute kind of neuropathic pain or isolated kind of you can use it this drug. Okay, and then gradually you can increase the dose up to 600 milligram. Okay, not more than that, but it has got a potential of somnolence, huge somnolence, and the edema. Okay. So yes, I told you angioedema, hypersensitivity, peripheral edema, dizziness, and somnolence. Okay. So one thing just would like to discuss with the exam going batch, that you must know the difference between pregabalin and gabapentin. The important point to remember is the pharmacokinetic profile. So pregabalin, it has got linear pharmacokinetic profile, like that is the plasma concentration is dose dependent. While the gabapentin, it has got non-linear, that is plasma concentration increases disproportionately through the dose. Okay. And this oral, talking about oral bioavailabilities, for all the doses, oral bioavailability is more than 90%, while this gabapentin has got maximum of 60% bioavailability when you are using still at 900 milligrams. Okay. Onset is faster, pregabalin. This is gabapentin is slower a bit. Okay. It takes 2 to 3 weeks for its entire effect. Okay. So yes, and BD dose and the TDS dose. Okay. So this is the difference you must know. Okay. Then recent and notable developments like alpha 2 delta ligands. So another compound is this microgabalin. Microgabalin has got a special property to bind the alpha 2 delta 1 subunit. Okay. So this is a newer compound, and this has been particularly effective in this diabetic neuropathic pain and other smaller neuropathic condition. Another compound which is under still this processing is crisogabalin. Okay, so microgabalin and crisogabalin and pregabalin and gabapentin. These are the 4 examples of alpha 2 delta subunit ligands. Okay, so when you get a MCQ and you need to find out which one is not there, so just try to remember all these 4. Okay, Felbamate, it's an obsolete drug now, but as in terms of MCQ, you just need to remember it can cause aplastic anemia and the fulminant hepatic failure. It was previously used in the case of trigeminal neuralgias. Okay, topiramate, yes, one of the important first-line drug, FDA approved drug for this migraine prophylaxis. Okay, so yes, headache. Other conditions like post-thoracotomy pain syndrome, intercostal neuralgia, you can use it. Okay. So what does this drug does? So it is inhibiting the calcium channel and sodium channels. Okay. So that is your ligand gated calcium and potassium sodium channels. So thereby excitatory glutamate pathway is getting inhibited, and while on the other hand the GABA is getting facilitated. Okay. So dose, yes, especially the 100 milligram of topiramate is used, also available in the market for migraine prophylaxis. Okay, so start with the lower dose, and then you can slightly increase the doses. Okay, important is it inhibits the carbonic anhydrase. Okay, so that why it can cause the kidney stones, renal stones. Phenytoin, the kind of older generation anti-epileptic. It has got multiple indications, but recently in pain, it's very less frequently used. So it inhibits the voltage sensitive sodium channels. One thing you just need to remember that what are the variety of sodium channels which are important in pain mediation. So this is, if you might remember, NaV 1.6 to 1.9. Okay, 1.7, 1.8, and 1.9. All three class of drugs, sodium channels are responsible for neuropathic pain. Okay, and neuropathic anti-neuropathic medications are acting on these receptors. Okay. So phenytoin, no need to know about everything, but one thing you just need to remember: it has got narrow therapeutic window. Okay, about the adverse effect. So it causes both short-term and long-term this adverse reactions. In this long term, you can get a gum hypertrophy, hirsutism, and hypersensitivity reaction. Apart from this, blood dyscrasias like megaloblastic anemias, osteomalasias. At higher concentration, it may cause this neurotoxicity. Okay, and the CBCs, NLFTs, and serum drug monitoring to be done at a frequent regular interval. Okay. Yes, this drug to be remembered. Excuse me. Yes, important drug is this carbamazepine. So I told you this is one of the sodium channel blocker and second generation of this anti-epileptic medication. And you might have everybody you might have used this drug, especially for trigeminal neuralgia, and this is a gold standard drug, Tegretol. Okay, so it was the best unifying for lancerating or electric shock like pain. Other condition where you can use is GPN, diabetic neuropathies, and pain associated with multiple sclerosis. Okay. So where does it act? There is two forms of sodium channel. That is one is open and another is inactivated. So what does a carbamazepine does? It binds to voltage sensitive sodium channels, leading to inactive conformation. So thereby it prevents the repetitive and sustained firing, leading to inhibition of action potential. Okay. Dose, yes. Again, I told you go low, but go slow. So BD to TDS dose 100 milligram, you can use it, and then gradually you can increase it to the maximum dose of 1200 milligram per day. Okay. Metabolism, yes, it's active. Just whatever I have highlighted, it has been asked as MCQ. So active metabolized 1011 epoxy carbamazepine. Okay. Again, this after phenytoin, this is the second drug which is the narrow therapeutic index. Okay, and most of it is again bind to plasma proteins. Side effect, yes, you have to monitor the CBC count. Okay, so just to find out how much and when to monitor, just whenever you are starting this drug, you have to get the baseline CBC data as well as the hepatic function data. Okay, and CBC, especially you are concerned about this platelet count, absolute neutrophil counts. Okay, and how regularly you should baseline you can do. Then first monitoring is required usually after 1 month, and thereafter regular monitoring can be done at 3 months. Okay, 3 to 6 months. Other adverse effect is hyponatremia, which is lesser with its congener, that is your oxcarbamazepine, genoxapac. Okay, and baseline CBC, yes, I told you. So important question is one is asked when to stop the therapy with carbamazepine. So whenever WBC count is less than 3,000 cells, or absolute neutrophil count is less than 1,500 cells, or the platelet count is less than 1 lakh. Okay, this is the complete contraindication for using this therapy. Okay, oxcarbamazepine. Yes, I told you chemically similar to carbamazepine, and this different you also must know. Apart from this pregabalin, gabapentin, Then oxcarbamazepine is better tolerated, means lesser number of side effects, and this has got fewer interaction as compared to carbamazepine, and it does not involve hepatic cytochrome P50, P450 enzymes for its metabolism. Again, lower incidence of idiosyncratic reaction, but just remember, hyponatremia is more with oxcarbamazepine. Okay. So number needed to treat. Important question that is asked again in the Viva to obtain a clinically meaningful response to treatment. So just you can, if you can see the table, just see this carbamazepine. It has got NNT of 1.4 to 2.8, especially for trigeminal neuralgia. That is the lowest drug. So that's why it is still considered to be gold standard for trigeminal neuralgia. Okay. So what actually defines the NNT? So number of patients you need to treat to prevent one additional bad outcome. That is in terms of medicine, you are talking about death or a stroke. For example, if drug has an NNT of 5, it means you have to treat at least 5 patients with the same drug to prevent one additional bad outcome. Okay. So these are the approved FDA indication for the drugs. Like you can see this asterisk mark. Gabapentin pregabalin is approved for post-herpetic neuralgia. For DPN, pregabalin is indicated. Then for trigeminal, carbamazepine is indicated by approved FDA. Okay. So coming to antidepressant, very few antidepressant are especially used for a pain condition, especially the tricyclic antidepressants. So what does tricyclic antidepressant does? It inhibits both actually the noradrenaline as well as this is the serotonin, this is the noradrenaline uptake. So the more amount of serotonin is available and the more amount of noradrenaline is available. So these are acting against your pain. Okay. Apart from the antipsychotic medications. So special indications are PHN, painful diabetic neuropathy, and all other neuropathic pain condition. Apart from neuropathic pain conditions, also used in the cases of this osteoarthritis, that is your nociceptive pain, and sometimes in the cases of the cancer-related neuropathic pain. Okay. So analgesic effect, yes, yes. Onset again, it's quite comparable with the pregabalin. Like I said already, around 7 days it takes around pregabalin. So it takes almost around 7 weeks for its peak effect. Okay. One thing just important I would like to remember that its adverse effect, because of its adverse effect, frequent adverse effect, it's less commonly used, like sedation, constipation, dry mouth. These all are anticholinergic side effects. Okay. And then there is arrhythmogenic and may induce seizure in overdose, especially when you are using in this elderly patient. There is again risk of benign prostatic hypertrophy exacerbation, and the cases of glaucoma patient, so you can precipitate acute congestive glaucoma. Okay. Because these are again and the anticholinergic effects. Okay. So one of the important thing, just remember this, just see this, amitriptyline is causing the maximum amount of sedation, anticholinergic effect, hypotension, cardiac effect, seizure, and weight gain. And out of among all this tricyclic antitriptyline has got minimum amount of this anticholinergic effect. Okay. So out of these, all this anticholinergic medication, sorry, this tricyclic antidepressant, nortriptyline is quite safer. Okay. So these are the drugs. When you compare it with this antipsychotic dose, this has got effective in the almost lowest possible dose. That is, you are using it in a 10 milligram. Okay, 10 milligram HS. You are using it. Okay, and other drugs I will discuss it with the SNRI later. Okay, so SSRI, very few drugs are available for painful conditions, especially this fluoxetine and paroxetine. Fluoxetine is sometimes used in the cases of fibromyalgic patients. Okay. Yes, and then in the case of the painful diabetic neuropathy. Okay. So when again, one thing just I would like to inform you regarding this fluoxetine drug. So fluoxetine should be taken in the morning. Okay. It's the only antidepressant that is going to be taken inside the morning, because once if you have taken in the night, what it is doing, it is increasing the amount of serotonin. So sometimes patient won't get adequate sleep. So you should use it in a morning doses. Okay. So that is why it can be used, fluoxetine. And fluoxetine has not got primarily pain indication, but it is altering your mood. So mood enhancing drug. Okay. So this is the fluoxetine we are using it at 25 milligram, then gradually increasing the dose. Adverse effect, yes, sleep disturbances. Okay. So that's why you should start using it in the morning dose. Apart from this medication, rest all other medications are usually given as a HS dose or night dose. Okay, initially started. Yes, serotonin symptom whenever you are using this SSRI with other MAO inhibitors or sometime this tramadol, because tramadol is also acting on the descending inhibitor. That's why increasing this serotonin. So it may lead to agitation, altered mental status, diarrhea, and all the sympathetic activities are enhanced. So what is the management? Supportive. You stop the drug, then you can use sometimes cyproheptadine to block further serotonin production. This again SNRI. Now one of the most important drugs for which we are using in the cases of the fibromyalgia. Okay, so this have got three drugs, especially the duloxetine, the venlafaxine, and the milnacipran. So out of these three drugs, this you can see the venlafaxine has got 30:1 serotonin to noradrenaline. Okay, and when you're talking about duloxetine, it's to 10:1, and the milnacipran has got 1:1. Okay. So duloxetine was the first antidepressant to have this specific pain condition, and this is the only drug which is antidepressant, which is quite effective in the case of even in the nociceptive disorder, especially they're talking about the osteoarthritis knee. And recently, I saw in one of the paper that it's going up. It has got approval for this osteoarthritic knee condition. Okay. So uses yes, painful diabetic neuropathy, fibromyalgia, and yes, degenerative arthritis. So yes, I told you inhibits the reuptake of both serotonin and norepinephrine, and it may be started at 20 milligram at bedtime. Then you can increase up to 60 milligram after 1 week. The venlafaxine, you can get a dose of start with a dose of 37.5 milligram and then gradually increase the dose. Then adverse effect, yes, hypertension, especially you just need to remember with the venlafaxine, okay, because of sympathetic overactivity, and sometimes may lead to diaphoresis. Yes, this is again NNT for neuropathic pain. And out of this, just interesting finding, you will see that tricyclic antidepressant has got lowest number needed to treat for neuropathic pain, but because of its adverse effect, which very less commonly used. Okay. Then FDA approved indications for various painful condition, and duloxetine is approved for neuropathic pain, fibromyalgia, and the nociceptive pain, while the milnacipran is approved for fibromyalgia. Okay. So till now we have covered three drugs for fibromyalgia FDA approved. One is pregabalin, second is duloxetine, and third is milnacipran. So this is the table which includes all these anti-neuropathic medications. So I think I've covered all this neuropathic medication. Now we move to NSAIDs. Okay. So NSAIDs, again, talking about this, consist of multiple unrelated compounds, and they are classified together based on the therapeutic potency. Okay. And this is the most commonly prescribed drugs, or you can say most misused drugs over the time. Okay. So non-selective inhibitors like aspirin or diclofenac, selective COX inhibitors are the COX-8s. The preferential COX-2 inhibitors are long-acting meloxicams, and sometimes called as COX-3 inhibitors are the paracetamol. Okay. So this is a table just for sake of information. Okay. Just in the MCQ, one question is asked, which one is propionic acid derivative or which one is acetic acid derivative? So just remember the mnemonic FINK, F-I-N-K. Florbiprofen, ibuprofen, ketoprofen, and naproxen. This is propionic acid derivative. Apart from else, everything is acetic acid derivative. Okay. You just need not to remember anything. Okay. Then I told you the mechanism of action. It inhibits the COX. Okay. So non-selective COX inhibitors are especially inhibiting both COX-1 and COX-2. Okay. What does COX do? COX does convert the arachidonic acid into prostaglandins, which is a powerful mediator of pain. Okay. So differentiating COX-1 and COX-2, COX-1 is physiologically expressed. So whereas what is the site? Especially the gastro GIT, then the platelets. While the COX-2 it's induced in a pathological condition, especially the inflammation. Okay. So the COX-1 is especially responsible for housekeeping functions like GI acid secretions, okay, like coagulation, and while the COX-2 is especially expressed in the kidney. So the non-specific NSAIDs like aspirin, it produces bleeding and tendency to peptic ulcer because this is inhibiting especially these things. Okay. So I told you the COX-1 has got physiological functions like renal functions, yeah, mucosal function and platelet aggregation. COX-2 is especially expressed in the inflammatory mediation when the cases of the pathological stress. Okay, and COX-3, yes, especially in the cases of brain. Okay, the paracetamol is acting over there. So absorption, the fact that I told one thing important is whatever the factors, those are affecting the gastric emptying may have profound effect on the course of the clinical effect of NSAID administration. So the something is increasing the gastric emptying. So definitely it is enhancing the NSAID action. Okay. Distribution, yes, 99% bound to serum. Okay. Elimination, it has metabolized by cytochrome P450 mediated, and especially the mostly it is oxidation by oxidized by oxidation and lesser to the glucuronide conjugation. Okay. Then coming to individual compounds, salicylate, yes, aspirin, it has got high fast pass effect and especially takes place in the liver or the wall of small intestine. An important thing to remember, it irreversibly inhibits the acetylation and consequent inhibition of COX, especially for 7 days. Okay, and the only one indication, especially which we are using in rheumatoid, is it doses. It can be used in a 500 milligram to 1 gram 6 hourly. Okay, and CVS, yes, 75 to 325 milligram. So disulfinol not used. Acetic acid derivative, yes, indomethacin. So indomethacin has got quite potent NSAID and especially used for especially the rheumatoid arthritis patients or the gouty arthritis or the osteoarthritis. And it has got relatively higher incidence of gastrointestinal side effect as well as the renal side effect. So lesser commonly used. Maximum dose you can use it as 200 milligram per day. Some sustained release tablets are also available and the dose of 75 milligram. Okay. So ketorolac, it's one of my favorite, especially I was using in the case of when I was particularly attached to anesthesia part. So this was used especially in the case of dental pain initially. So they used ketorolac dispersible tablet, especially the 10 milligram, and it has got duration of action for 4 milligram. For every after every 4 hours, you have to repeat it. Okay, and maximum then comes ketorolac injection. Ketorolac injections are also available in dose of 30 milligram. So 30 milligram it's useful for 6 hourly, while the 10 milligram was used for 4 hourly. So it has got you have to give it at least 4 to 6 hours. Okay, ketorolac. Yes. Okay. And it's one MCQ. It's asked regarding this ketorolac. It's quite potent or equivalent to this morphine when compared with this acute postoperative pain. Okay, ketorolac. So, but you shouldn't be using it more than 3 to 5 days because it has got a high incidence of adverse effects, especially the hemolytic anemias. Okay. Then the diclofenac. Diclofenac, yes, 50 milligram dose tablets you can use it. One of the most commonly drug available over the counter. Sometimes entry coated diclofenac is available, which resists dissolution at lower poses, especially in the gas and stomach, and thereby released in the duodenum. Okay, so lesser incidence of gastritis with this case. And when you are using it for longer duration, definitely hepatotoxicity you are going to get. Then comes your propionic acid derivative. I told you ibuprofen. Ibuprofen is quite one of the safest this NSAIDs, and half life is almost around 3 to 4 hours. And yes, it is rated as the safest traditional NSAID by the spontaneous adverse reaction reporting in the UK. Okay, so ibuprofen, one thing I just need to remember, whenever you are using ibuprofen in combination with the aspirin, it may antagonize the irreversible platelet inhibition by the aspirin, thereby treatment of the patient which who are at the increased risk of cardiovascular with may limit the cardioprotective effect of aspirin. Okay, so just be careful about that. Ketoprofen, yes, the maximum recommended dose is 300 milligram per day. Flurbiprofen, yes. The only highlighted thing is that this is going to be asked in your MCQ, or it has been asked in MCQ. Dyspepsia, it was the most common side effect with the flurbiprofen. Naproxen, I am using it for this acute headache conditions, mostly the migraine. This you can use it in dose of 250 milligram OD, BD, or TDS sometimes. Okay, but important thing to remember, you should never be using it a pregnant patient. Regarding the pregnancy, none of the NSAIDs are safe. Okay, especially they are FDA. FDA has issued a red label warning when you are using more than 20 weeks. Okay, so if you are using any NSAIDs more than 20 weeks, after 20 weeks, you are definitely going to do a crime. Okay, so naproxen, it's quite effective in this rheumatoid arthritis, osteoarthritis pain. Okay, 250 milligram every 8 hours. Okay, so this is the complete list of propionic acid derivative. Sorry. Oxychem, yes. The longer duration of this longer acting NSAIDs, especially the oxychems, are available. Pyroxychem, especially the gouty arthritis, the inflammatory arthritis, OD dosing is available, and 50 to 20 milligram tablets can be given. Okay. The pyrazolone derivative, phenylbutazone. You must know this adverse effect like aplastic anemias or the granulocytosis. Then anthracnic acid derivative, mefenamides. Mefenamides has got been, I think, recently been banned or for in the substances of severe pancytopenia because okay. Now, then comes nabumeton. It has got the only MCQ thing I have written here, non-acidic chemical structure. Then there comes your COX-2 preferential meloxicam. Again, it has got once daily administration potency. So doses 7.5 to 15 milligram. Okay, especially used by this USA. It was used for this osteoarthritis patient when longer acting. Okay, then comes COX-2 selective inhibitors. COX-2 selective inhibitors, especially developed with the aims. Yes, it has got. So COX-2, you might be knowing, it is causing lesser amount of GI side effects, or and then comes this all other the blood discourage. Yes, lesser amount. But definitely the two drugs which were banned were in the selective COX-2 inhibitors were rofecoxib and the valdecoxib. Okay, the yes, the one which we are still using is celecoxib and this etoricoxib. Celecoxib regarding is your, it is contraindicated in the patient with a sulfonamide allergy. Okay, then rofecoxib is banned because of cardiovascular event, and then valdecoxib is again banned. With okay, the one drug which we are frequently using is etoricoxib. So highest recommended dose is using for 60 to 90 milligram for this acute painful condition, and the maximum dose you can use is the 120 milligram. Okay, especially in this dysmenorrhea patients or acute dental pain patients and this chronic pain condition. When you are combining with this muscle relaxant, you can use this drug. Lumericoxib, yes, it has got highly selective for COX-2. Okay, and it is got it has shown clinically to provide analgesia for the treatment of osteoarthritis knee condition, and it has got reduced incidence of GI side effect. Again, this longer duration drug. Then your paracetamol, it has got no significant peripheral prostaglandins inhibitor. Important thing to remember for exam going patient, guys. One thing just I need to tell you about this: only 10% of the paracetamol is getting oxidized via the oxidation. Okay, 90% is getting oxidized by the glucuronide or sulfation. Okay, and this 10% oxidation gives you the NAPBQ1, that is our N-acetyl parabenzoyl quinonamide, and this is going to be a hepatotoxic, and treatment is your N-acetyl cysteine. Okay, maximum dose is 4 milligram, and in case of hepatic injury, you can keep the dosing up to 3 grams per day. Okay, adverse effect, yes, it can affect all your systems. Talking about this overall adverse effect, hematological adverse effect is mostly with this aspirin, irreversibly acetylates COX enzyme. I told you, and it takes around 7 to 10 days for complete reversal of this therapy. Then hematologically, yes, mostly NSAID potentiate the anticoagulant effect of warfarin via displacing the protein-bound drug or by inhibiting the metabolized by my hepatic microbiome. As I told you, the most of these NSAIDs are protein-bound, like somewhere 70%, 60%. So this drug warfarin, whenever you are using it in these patients, keep it as a clear. It comes with some warning. Okay. Some cardiovascular, as I told you, rofecoxib, valdecoxib are especially inhibited. It has been warned as a red label drug in the US FDA. And then unbalanced biosynthesis of prostaglandins and prostacyclins may lead to atherosclerosis and thrombosis. So this is going to be your COX-2 inhibitors may particularly. Then comes your gastrointestinal. Yes. Gastrointestinal risk are especially one whenever using your NSAID drugs for especially elderly more than 60 drugs, there is high risk of gastroenteritis, especially if the patients are having the history of dyspepsia or they have history of peptic ulcer bleeding. You must be careful regarding a prescription of these medication. Okay. Then upper GI event, when you are using it, especially in these cases, just try to prescribe them some PPI along with these medications. Bone healing, yes, it definitely hampers the bone healing because it reduces the blood supply to the bone, also inhibits the inflammatory process, then thereby definitely reducing the bone healing. Okay. Allergic reactions, yes, it can cause two types of allergic reaction. One is this the syndrome of asthmatic attack in patients with the vasomotor rhinitis, and then in second category where it causes urticaria and both may be related to inhibition of prostaglandin synthesis. Okay. Renal toxicity, the postulated mechanism with inhibition of renal synthesis of prostaglandins, which is the a kind of protective way for preventing your kidney. Thereby, it prevents the blood flow to the kidney, and this is getting inhibited by a frequent using of your NSAIDs. Okay, hepatotoxicity, yes, aspirin. CNS, sometimes it may cause aseptic meningitis, especially this has been reported with ibuprofen, Sulindac, yes, that has been withdrawn from the market, and Tulmintine, again withdrawn from the market, and naproxen. Naproxen, especially the neonates. If the pregnant patients have been used, the naproxen has been indicated to so that it can cause neonatal meningitis. Okay, so these are the complete list of adverse drug effects. So take home message for this NSAIDs. Skeletal muscle relaxation. I just it was not included, but I just want to show you the list. So one class indicates antihistaminics, that is orphanadrine, the CNS depressant, this carisoprodol. It's included in CNS depressant. Then alpha-2 adrenergic agonist, that is your tizanidine, and the TCS is cyclobenzaprine, and then there are GABA agonists, that is your baclofen. Okay. So this is antihistaminic, CNS depressant, carisoprodol, chlorhexanone. Okay, just need to remember about chlorhexazone. It inhibits the multisynaptic artery node. Okay, one drug is acting on both monosynaptic and polysynaptic. So chlorhexazone acting on the multisynaptic reflex. Okay. So metoclopramide, vintoxolone, this one. So baclofen is the MCQ is asked. It inhibits the both monosynaptic and polysynaptic transmission along the spinal cord. So thereby inhibiting. So you can start with a dose of 5 to 10 milligram in the night and go on increasing the dose. Okay, up to 40 milligram. So TCA compound, cyclobenzaprine, yes, you are using it in some of them combined with some NSAIDs, okay, and it has got deleterious side effects like arrhythmia, seizure, and myocardial infarction. Then tizanidine, again, it has got centrally acting, and this is alpha-2 agonist that is quite similar to clonidine. Okay. Then thiocalcoside, the most commonly used this muscle relaxant available over the counter. This is this has got activity to soon interact with a GABA type of A receptor. Okay, and the maximum dose recommended oral dose is 8 milligram every 12 hours. Okay, for not more than 7 consecutive days. Just remember this thing: not more than 7 days. Okay. So coming to your last topics like opioids belong to this G-coupled. These are drugs are acting on the G-coupled receptors, and ultimate is they are inhibiting the adenyl cyclase enzyme. Okay, so there are three types of opioid: mu, kappa, and delta. Okay, and once these drugs bind to these particular receptors, so what does they do? They inhibit the calcium influx, and as I told you earlier, once the calcium influx is inhibited, so the other neurotransmitter or the chemical agents are coming. So potassium is coming up. So potassium is kind of inhibitory for the neuron. So ultimately the pain signal is getting inhibited. Okay. So this is the adenyl G protein coupled receptor. Once the ligand bound to this transmembrane potential, there is recyclation. Then there is ultimately this is GTP is converted into adenyl cyclase that is inhibiting your from ATP to CAMP. So the pain pathway is getting hampered. Okay. So as I told you, the inward the calcium influx is inhibited and the potassium influx is enhanced. So ultimately causing hyperpolarization. So there is inhibition of the pain signal. Okay, this I've already shown you. Okay, yes. Hmm. So I told you already, inhibitor calcium complex. Done. This one is also done. Okay. Sorry. So what are the different sites where opioids are acting particularly? Okay. So one is your directly acting at the site of injury. Okay. Then there the nociceptors are located. So there the mu receptors are the primarily indicated. Then the pain fibers are getting transmitted to the dorsal horn of this spinal cord. So again, there again mu transmitters are prominent. So the mu receptors are especially responsible for pain inhibition. Okay. So these are the opioids acting at the periphery, and from the spinal cord, they are ascending via this pain pathway to the ascending reticular formation, where there is again abundance of opioid receptor. Then there is thalamus, then striatum, the limbic system, the cortex, the hypothalamus, the brainstem, and PAG. These all are areas where the opioid receptors are abundantly located. Okay, so see, one is the site of pain. Then and this is the lamina 2, that is your substantia gelatinosa. This is the where the opioid receptors are abundant. Then comes your sorry, this is the spinothalamic tract, the pain pathway. Then comes your number three. Number three is your thalamus. Thalamus where the prominent. Then comes your somatosensory cortex. Then insular cortex, the cingulate cortex. Then in the descending pathway, the PAG, the periaqueductal gray matter, the midbrain, the raphe nucleus in the medulla, and again dorsal horn of this spinal cord. Okay, so these are the location where the opioid receptor. So what are the effects? Opioid receptor mu causes this muscarine. In the pharmacology section, you might have read this muscarine and mnemonic. So meiosis, urinary retention, sedation, constipation, analgesia, respiratory depression, and then inhibiting the muscle increasing the muscle rigidity, and the negative bile reduces bile flow, and it may cause euphoria. Then kappa. Kappa is related with K for constipation. C. Okay. Then it may cause dysphoria. Then delta. Delta is associated with analgesia and sometimes modulate the release of neurotransmitters. Okay. Then yes, what does it how does it reduces the ventilative suppression? That may be associated with directly dose dependent or mu2 receptor associated, okay, inhibiting the brainstem. Okay? And how it's causing rigidity, interaction with the dopaminergic and GABA responsive neurons. Okay, then various drug. One is the endogenous opioid, other is the exogenous. So endogenous is your endorphin that is acting on mu receptor, dynorphin that is acting on kappa receptor, and enkephalin that is acting on delta receptors. Okay, endogenous opioid, what does it do? So these are actually inhibiting the pain suppression system. Okay, so happy hormone, that is endogenous opioids. Okay, so especially I told you all those areas of the brain where they're particularly residing and helping to fight this pain. Exogenous, definitely it can be classified on two way on the basis of source, from where it is acquired, and on the basis of the receptor interaction. So on the basis of source, natural plants are poppy plants where these drugs are derived. The phenanthrene compound, that is your morphine, then the benzyl isoquinones, that is papaverine. Okay, then semi-synthetic diacetyl morphine, DAM, and then from codeine and oxycodone and hydrocodone is obtained, and then from thebaine, buprenorphine. Then synthetic, the most commonly used anesthetic agents like fentanyl, which is 100 times of more potent, and then sufentanil, almost 1,000 times more potent. Okay, so these are the structures. I told you this one. Okay, so opioid agonist, yes, morphine, hydroxymorphone, codeine. Just need to remember this drug, especially the second, the middle part of this, where the MCQ is getting asked, which of them is agonist, antagonist. So just remember buprenorphine, pentazocine, okay? And what are the pure antagonists? The naloxone, nalbuphine, and the naltrexone, okay? So morphine about just remember this drug. It has got poor lipid solubility as compared to this fentanyl. T half is 2 hours. So almost it is duration of action is 4 hours. So one thing when you are prescribing, don't prescribe as a OD or BD dose. Okay. So duration of action is 4 hours. Whenever you are using it in the cancer patients, so just try to prescribe it at a regular interval, just like every 4 hours. Okay, not less than that. Okay? So yeah, dose must be reduced in the cases of renal or liver failure. So the initial dose you can start is a 10 milligram 4 hourly, and then you can go on increasing the dose. Okay, especially in the renal and liver patients, you just need to reduce the dose to 5 milligram 4 hourly. Okay, So 5 milligram usually tablet is not available. So 10 milligram tablet need to be broken and dissolved. Okay, especially the cancel pain, it is useful. And the pain where it's not been effective is one is your neuropathic pain. Another condition where even in the cancer it's not useful is the capsular pain, like liver capsule pain. Okay, so it's not effective in those cases. And one is the bony pain. So in these three conditions, you must remember the morphine is not effective. Okay. So morphine, I told you everything. This is the side effects, especially the nausea and vomiting most commonly. That's why whenever you are prescribing the morphine, you need to prescribe antiemetic, and the most important thing, you have to prescribe a laxative. Okay. So codeine, yes, used in a cough syrup, antitussive material. Okay, then the meperidine, that is a pethidine, that most commonly drug used in intraoperative severing. Okay. Yes. Then methadone. Methadone is the one of the, I think for beginners, it's kind of one of the unsafe drugs. So whenever you are using methadone, it usually takes 10 minutes to 20 minutes to produce analgesia. And in orally, it takes around 45 minutes to produce analgesia. Okay. And it causes you start with a dose of 2.5 milligram tablet. Okay. And definitely it has got adverse effect in terms of cardiovascular adverse effect like QT prolongation, anticholinergic side effect. And important thing to remember is your unpredictable drug levels. Okay, so very few amount. So it's I think 6 to 8 to 10 hourly you can use it. Okay, 2.5 milligram tablets. Okay, methadone. I think very few centers are having this tramadol and this methadone tablet. Tramadol, yes, tramadol or tapentadol. I think most of the us are using it. So you can use it around BD, TD, or quite sometimes 4 times a day. Start with this lower dose. Say you can say combine with this paracetamol, like this Ultracet paracetamol tramadol combination. So you can use it half dose TDS and then gradually increase because sometimes, especially the elderly patients, are coming with this constipation, and younger patients they are coming up with this more amount of nausea complaints. Okay, so try to go low on the slower side. Important thing is just you need to remember that has got this these are acting on this descending inhibitory pathway. Okay, so it has got a quite good effect in the case of neuropathic pain also. Okay? Fentanyl, yes, patches are available. Yes, how much patch is effective for almost 72 hours. Okay, and whenever you are applying this fentanyl patch, just need to one thing need to remember: it takes around 6 to 10 hours for its quite peak effect. Okay, just you need to advise those patients, and you have to remove this patch after 3 days. Okay. And then yes, the mix. These are the mix agents I told you. Then yes. Hmm. I think yes, buprenorphine. Buprenorphine is antagonist at kappa and partial agonist at mu. Yes, it has got almost 10 to 50 times more potent than morphine, depending upon the dose of and mode of administration. Okay? So this is the conversion table. You must remember, morphine oral is almost IV is almost 3 times more potent than oral doses. One thing is methadone. You can see 1 versus 3. Okay, so almost 3 points more potent methadone. Okay, fentanyl is almost 100 times more potent. Tramadol is 40 and then 4 times more less potent than compared to morphine. You just remember to need to see fewer drugs. This opioid conversion table. This antagonist naloxone. This is the shortest acting. Then nalmefene and then naltrexone. These are pure antagonists. I told you these are opioid-induced constipation. Then the transdermal patch. Two types of patches are available. One is the reservoir or membrane control system. Here, the reservoir system in the patch holds the drug in the form of gel or solution, and delivery is determined by the rate controlling that is available between the drug reservoir and the skin. But in the matrix system, there is a continuous release of the drug. Okay, this next picture it will be great. So this is the matrix system on the right side. This is the reservoir patch. The reservoir patch, there's a layer of contact adhesive between the skin and this rate controlling membrane. Okay, so the drug is released slowly. Okay, here the drug is released continuously, matrix patch. Okay. I told you this needs to be removed after 3 days. It can be, and this buprenorphine from 5 to 7 days. Okay. So just need to say something about this table. From step 1 to step 3 was determined by WHO. Step 4, everybody says that what is the new form of this newest step for this WHO is our intervention. But till this time, I remember, I again say this word, that till this time, step 4 has not been recommended. Okay, this is only in the literature. Okay, so whatever the original WHO ladder says, that we have got 3 steps of management of pain, so especially the cancer pain. So it remains the same. WHO has not said step 4, but it has been advised to include the step 4 in the original. Okay, just remember this thing. So step 1 is non-opioid analgesics and NSAID. Step 2, like weaker opioids. Step 3 is standard opioids, strong opioids, and step 4, yes, the proposed one, like intervention. Okay, so you can switch along with this. Along with this, you can add the adjuvant plus minus. Okay, in every step. So this was the practical scenario for methadone. So whenever you're using 20 milligram of morphine, the methadone equivalent is 5 milligram. Up to 60 milligram, you can say 60 to 90 gram, you can just increase by 5. Okay, but after that, it's almost remain the same because of high risk of respiratory depression and arrhythmias. Okay, local anesthetic, I think I shouldn't be covering this. Okay, that's all from my side.
Thank you, Dr. Ravi, for a wonderful presentation. You
Thank
covered
you, sir.
all aspects. I think almost everything is covered, pharmacotherapy.
Yes, I
So I
tried to
was
cover
just checking
almost.
the chat. There's no questions from the audience.
Mhm.
So if you want to ask any questions, but no question is there. So one
Yes.
more thing I want to this thing add, as you said rightly, the neuropathic pain medication like pregabalin and gabapentin, you have to start with the lower dose and increase it because that is very important. That is the most
Yes, sir.
important thing because we have seen 400 milligram gabapentin, the patient don't get sedation, and with 100 patient gets a maximum sedation. So
Yeah.
one incidence I want to share here,
Yeah.
there's one preparation as gabapentin has come, that is a GRS, that is a
Yeah.
release. So
Okay.
24 hours preparation. So I
Mhm.
just wrote in the beginning because there's a new drug to pharmacists also. So I just wrote gabapentin 300 or gabapentin GRS 300, something like that. So I
Okay.
wrote 300. So that
Mm.
pharmacist didn't know it's a, and all the drugs, they are named with the GABA word into that. So the pregabalin also have GABA word into that
Okay.
names I'm into. So instead of gabapentin GRS 300, that
Uh-huh.
pharmacist gave us some pregabalin 300 with some GABA
Oh,
put into that. So he got confused and patient
oh.
took pregabalin 300 for two
Uh-huh.
three days. Then I suddenly got a phone call from patient. Ki, sir, what
Uh-huh.
medicine you have given? Patient is
Uh,
sleeping since 3 days and he's not got up only. So washroom also we have to just hold her and take her to the washroom. So then I realized which medicines you took. So I just asked them. So they didn't come. So I said visit immediately, but send me the photographs. So there I
Yeah.
got to know that they have taken a pregabalin. So you have to check also which drugs they've taken.
Yeah. Definitely. Uh-huh.
Important. And one more thing, we should always tell them not to drive when you.
Yeah.
So even if it is a mild dose, you just mention that because you are safe that way. So sometimes sedation can be really bad. So
Yeah.
otherwise, overall, very great presentation, very nice.
Thank you, sir.
Covered everything. So I'm just checking. There's no questions from the audience. Yes, just a minute. Somebody's asking, can you share the PPT? So, are we sharing the PPT?
I don't have any idea, sir. Same.
Uh, so just, I think I can, if anybody wants that, they can personally get in touch with Dr. Ravi. I think he can do that. So that is the for how many days we can give ibuprofen and tramadol? So that is
Ibuprofen 5 to 7 days. Okay, sir. And this tramadol you can use for initially what I do used to do 2 weeks. Okay. So initially for the first time whenever the patient is receiving tramadol, I start with this ultraset semi. Okay. This is like half dose of this actual dose. Half dose TDS and then give it for almost 2 weeks for especially for this ONE patients. Okay. Along with apart from other reasons. Okay. But if you are using it as a BD dose, some practitioners are using it. Use it in a full dose, and then you can give it for another, you can say 14 days.
Okay, okay. So actually, the tramadol, this thing, as we know, Ultraset, the pack insert, they have mentioned something like a 7 days or not more than 5 days or something like that. So, but that is a big debate because the Johnson and Johnson, the people who visit us, they tell tramadol is very very safe, and they have studies up to 6 months about the safety, continue 6 months. So, I think, but we have a Ultraset. We still have some relief because we can give for longer duration than the NSAIDs, definitely.
Yeah, definitely.
Only thing is some patients, only 3 to 5% patients, they don't tolerate tramadol and they show such a bad symptoms. So we have to be aware about that. Severe nausea and headache and so everything. So that is one thing. Otherwise, tramadol is a very good drug, right?
One question I think Sujata is asking: drug of choice for migraine in pregnancy. So first of all, drug of choice is again paracetamol. Okay, so if you want to use any drug in pregnancy, you cannot use any NSAID. But if you want to use for a single episode for less than, I read 2 papers where they were mentioning especially about this uh, diclofenac. Diclofenac, you can use it in a less than 20 weeks of pregnancy. So for 1 or 2 dosing, not more than that. But the FDA especially does not recommend this. Okay. So only the paracetamol dose is more than 650 milligram. Okay. 650 milligram or higher, it's you can say the drug of choice migraine in pregnancy.
Okay.
Anything else? No. So I think every question.
So a lot of thank you messages for you, Ravi.
Thanks, sir.
Wonderful presentation.
Yeah. Thanks.
So if no questions further, so we can end the session here.
Yeah.
Right?
Yes, sir.
Is Dr. Bangar is around? Dr. Kashna?
No, I don't think so, sir.
Okay. Okay. Thank you, Dr. Ravi, for nice presentation.
Okay. Thank you, sir.
Okay, great. Thank you all for joining. All the best. Good night.
Good night, sir.
Good night.